Okay, so this is where I am currently, and I see some familiar faces here. Okay, so yes, I remember some of the doctors here. I used to be at Mayo Clinic, and then I moved here. So it's nice to be here. The topic, of course, is AI use, and I don't know if the slide is projecting well or not, but so essentially, we use AI in our general lives. We started using AI without even realizing we are using AI. We do, we booked airline tickets, we do all kinds of things, and we are talking to chatbots and we are doing AI generated things. So, how do we use AI in our practice, in our life, to make the healthcare professionals do a better job and not waste time in doing mundane things that take up a lot of time? So make more eye contact with your patient, not to be staring at a computer screen while you're seeing your patient, so they feel like they are there and they're getting your attention. So some of the things that I have here on the slide, I need to put this on a different view. Can someone help me? Can you put it on the big view? I don't have any notes, so I want to move it because my view, the screen view here is really, I don't want this view. Can you put it on the full screen? Yeah, I don't want the duplicates, please. Thank you. Yeah, yeah, the whole screen. Yes, thank you so much. Okay, so basically screening, classification, quantification of test values. All this can be done through AI generated tools. You can also do prediction of complications, recognition and management of modifiable risk factors. These also can be done. So classification, risk stratification is very important to be for futuristic use as well as now AI, and I'll show you some examples using AI. Now, there are, for us, there are three populations we talk about. The population without diabetes, but maybe at risk for diabetes. There's the folks that have diabetes, and then there are those that develop complications. So the goal of AI would be to screen population that are at risk for diabetes, mainly the pre-diabetics, those who are overweight and maybe have other comorbidities, fatty liver, for example, and those who have diabetes, and then you want to make sure that they are getting proper education, nutrition therapy, physical therapy, blood glucose monitoring, as my speakers before me mentioned, and of course, medications. And all this can be done stratified in a way that you use AI to its maximum ability, but with caution, okay? And I'll mention that too. And then screening of complications, recognition of referable patients, and prediction of progression can be done using AI tools. So we have opportunities, we have challenges, and we have future directions. So let's talk about one by one. What are the opportunities? What are the ways to do AI? So the AI models for early detection of type 1 diabetes risk before clinical onset. So why? Why do we need this? Because in my country where I live, and have lived for 30 plus years, approximately 64,000 Americans are diagnosed annually, with 40% of them are unaware. This is only type 1 I'm talking about, not type 2. The first study developed age-specific machine learning models that identified risk up to 12 months prior to diagnosis, achieving high sensitivity. This study was funded by Sanofi. It is a paper that came out. You can all look at it. And they showed that you can identify people at risk for type 1 up to 12 months before diagnosis. And it had a high sensitivity, 80% for ages 0 to 24, and 92% for adults. And it reduced the false positives compared to traditional methods. So that's a good AI tool they used. I'm not saying it's all perfect, okay? Believe me, these are not perfect tools, but at least we have something to start with. The second study that was done utilized a large health claims database. So in America, we have the health claims, and we can tap into that database and they trained a model that increased the detection of efficiency by over 18-fold, revealing that 29% of diagnosed individuals have been misclassified as having type 2 diabetes. So they actually had type 1, they were misclassified as type 2. So these are important machine learning tools that one could put to use, because for a single doctor or a single person to do this kind of large scale work is pretty much impossible. So the future of this is these researchers that did this early 2 studies that I'm discussing here, they plan to validate and refine a clinical decision support tool by integrating these AI models with electronic health records, which is what we do in America, and I'm sure you do that here too, you try to integrate the electronic health records within the institutions and between institutions. So when people migrate or move around, you can have some unified system of finding out what is going on with them instead of having to start from scratch. And then follow-up studies will explore enhancing model performance through additional data sources. So you need really large data, and this is a fertile country with data, right? You have lots, your population is high, you have a lot of people with diabetes. It's a perfect place to start putting together large databases that I'm talking about. So now what are the other things that have tools that are already there? There are tools in America, and I'm sure you guys use certain tools too, for glycemic control and insulin dosing. And so these tools are like Gluc Alert CDS. They can reduce hyperglycemia by 10% in outpatients and assist with basal bolus dosing in hospitals. Then you have real-time alerts and reminders. So systems provide alerts for necessary tests such as LDL-C screenings, fatty liver screenings, etc. In our clinic, in our hospital at UAB, all the providers get an alert for the EMR, which gives you the FIB-4 scoring. So that's another tool we can use. Data integration can be done, performance metrics can be used, improved compliance can be done with guidelines by using AI tools, efficiency can be improved, the workload of clinicians by automating tasks, and mixed outcomes. So some research shows significant improvements in glycemia. Others note that the impact on long-term outcomes can be inconsistent. So, we've still got ways to go. We are not absolutely sure what's going to happen. So there's some FDA-approved decision support systems. This is US FDA approved. So the Beta Bionics, iLet Bionic Pancreas, the DreMed Advisor Pro, the Medtronic MiniMed, as you know, 780G, Dexcom Smart Bolus, T1D1, Dexcom Stelo Glucose Biosensor. These are all available. And the last one, the Stelo Glucose Biosensor, it's over the counter. So people can go to any store and buy it. You don't need a prescription from a doctor. And many patients are using these nowadays. Our patients tell us they use them to monitor their blood glucose, as our speakers before were mentioning, to see what happens, impact of nutrition, etc. So this slide, I'm not going to show again because everyone's going to talk about it. I think my husband is talking about all these things. But this is the history of the AI data-driven control that everyone's been talking about, how it has evolved over time. And then, the artificial intelligence, machine learning for improving glycemic control. We all are working towards it. So again, I don't want to show that. Look at this slide. This is an Amazoning healthcare. Look at how many remote monitoring devices we have available in our hands now. You can go into Amazon.com and buy all this. You can have watches, you can have monitoring of Fitbits, this, that, everything you can do. You can do microsampling at home. You can wear these things. And so there are so many tools available to us. And if you integrate all this, you pretty much know what's going on with the person. Continuous glucose monitoring, again, I don't want to go into it. My point being that different human beings have different glucotypes. So they respond differently. So basically, this study was done by Dr. Snyder and McLaughlin and was published in 2023. They showed the 5 target behavior changes to improve metabolic health in humans. So one is the glucose spikes that come from different foods, etc., the calories you're consuming, the fiber intake, which can slow down things, activity, of course, which improves, and intermittent fasting, which is, again, the jury's out on intermittent fasting, because if you want to eat 10 hours a day and you eat like crazy, you're not going to have any benefits of that. So I'm not a believer in intermittent fasting, but I'm just showing this to you, what they showed. And what they did was they did a whole bunch of remote home monitoring. So this paper came out, and Dr. Snyder did some microsampling to do omics research, and they did lab processing. They put the phenotype together, and they came up with lipidomics, metabolomics, proteomics, and they looked at cytokine panel, cortisol, total protein, and hormones. And this is the future. This is AI generated, okay? They took this data, put it into an AI generated tool. And then they also studied people, because you need to validate your data with humans. So what they did was took 55 people, gave them 7 different types of carbs, identical amounts, and look at the responses. Someone had a spike with bread, but didn't have spikes with pasta or potatoes or rice. Somebody spiked with rice. Somebody spiked with just grape. So, different people or past us. So they didn't respond to the other curves. You see the curves are down, and this is CGM curves, okay? And the other people have spiked. So there are different subtypes of human beings who have spikes with certain foods and not. So don't generalize that everyone will have a bad spike with a carbohydrate. It need not be true. So what they came up with is lifestyle profiling and prediction of metabolic characteristics. And they put this all into this giant algorithm, which is published. And they came up with various factors. And I'm going very fast because I have 15 minutes to deliver this talk. And actually it takes 45 minutes usually when I present it. So they sub-phenotype patients based upon their CGM data and all the phenotype they gathered, and they call them either muscle insulin resistant or beta cell response is slow, or incretin hormone response. And when I spoke to Dr. Snyder, he hasn't been able to tease it out because remember, he's just using CGM data. He's not using hormone data, et cetera, yet. So to predict glucose variability, et cetera, without understanding insulin, what's happening to the other hormones, insulin, glucagon, et cetera, is kind of hard. But this study, I thought was of interest to everyone here. So what they did was, they did a type 2 diabetes pharmacotherapy de-escalation through AI-enabled lifestyle modifications. This is all AI-generated trial, randomized clinical trial, which was done through a smartphone app interface. The participant received continuously some adapting personalized recommendations about 4 things: food choices, physical activity, sleep hygiene. Sleep is very important. If you don't sleep well, glucose will be off. So sleep is important, and deep breathing exercises, which is coming up now because it works through the vagal, parasympathetic, sympathetic activity. And so what they found was by doing these curated personal preferences and reinforced through periodic, front-loaded human telecoaching sessions with licensed providers, nurses, certified health coaches, they achieved a HbA1c lowering of 1.3% with this coaching app. So these are 2 groups of type 2s. They all have, they're taking meds, et cetera, but this one group really benefited with this. So we won't dismiss other things easily. So we need to treat people, but we also need to look at other factors. So here's something that has really worked well for AI is diabetic retinopathy. So AI tools have been used. There are 3 that are US FDA approved right now. There's iArt, IDXDR, and there's AIDS. And these are, it's very easy. It takes literally 5 to 10 minutes. The patient comes to the clinic, the outpatient clinic, wherever they get this exam done, and then it goes into this software and it predicts their risk for diabetic retinopathy. And I looked up, and India also has your own. And so I looked at what India has, and it's up on the screen. And so you have various AI tools, et cetera, that you're using as well. We have our 3 that are approved. You guys have some, and there are a lot more in the pipeline. And of course, I wanted to mention Dr. Mohan's Diabetes Specialty Clinic, which is using AIDR to address this massive screening gap that exists in this country. So of course, kudos to him for doing that in rural patients. So now, last, what I wanted to touch upon is the core ethical issues. It's great to use AI in our practice and in what we do and how we come up with future algorithms. But the most important things are, we should not forget that the human intelligence is far superior than artificial intelligence. So we should not let the machine give diagnosis and management. We should take its advice maybe if we need it, but we need to apply our own knowledge and understanding for treatment of patients. So I needed to show you these cartoons, which you can see. These are all the things that are important ethically. So data privacy and security. So AI systems require vast amounts of personal health, continuous glucose monitoring data, raising risk of breaches, and it requires robust informed consent. So you should not be doing this without asking your patient, yes, I'm putting all your data together and uploading into the cloud and is being used by multiple people. Algorithmic bias and fairness. So if the training data lacks diversity, AI can give false recommendations and it can provide inaccurate predictions. If you only study like certain parts of, when I was at Mayo Clinic, I only studied white people, Caucasians, because there was no access to others. But when I moved to Alabama now, I have African Americans in my patient population. So I'm able to get more generalized information. So that's very important for AI tools. Transparency and black box problems. So many machine learning models are not easily interpretable. The engineers and mathematicians that I work with will tell me it's going into this box and it's generating this data. I just want to know how that box works, and they won't be able to give me answers all the time. So there are a lot of problems with these, with transparency of the physicians understanding what the mathematicians and algorithm developers are doing behind the scenes. So ask questions. Accountability and liability. It remains unclear. Sorry, I'm going to finish up. Who is responsible? The physician, the developer, or the hospital? So who's liable if something bad happens? Make a wrong diagnosis, go with it. Are you going to be sued, or is the hospital going to be sued? So keep that in mind. And then patient autonomy and human oversight. Above all, it is my clinical judgment, my oath as a doctor to take care of my patient and the patient to make a decision with me and not allow AI to take everything. So this is very important to summarize the future directions, that Alexa can book your appointment, it can do everything for you. And then guess what Alexa did? Went ahead and charged and told everybody in the world that this person had this bad diagnosis, and you can read what it was. And so I leave that thought with you, that make sure there's privacy, confidentiality maintained, and as you use AI, use it to its best advantage and for the future. Thank you for your attention. Email me if you have any questions.